Healthcare is a multifaceted industry which employs all types of professions and is bound by a multitude of statutes and regulations. To help you understand how a coder fits into the healthcare industry, we will discuss coding as a profession and how the coder fits into the physician office, as well as differences of services that are provided by hospitals and those that are provided by physicians. Although some coders may not be involved in billing, it is important to understand some billing aspects in order to perform more effectively. To help, we will discuss the different types of payers for medical services, the RBRVS system for fees, medical necessity, and the ABN as it relates to physician services. It is also important to discuss the varying regulations that affect us as coders. This includes privacy and security, compliance, rules, and audits, and then using tools such as the OIG work plan to identify possible areas of concern. We will wrap up this chapter by talking a little bit about AAPC and what it means to be a member of the AAPC. Every time a patient receives healthcare, a record is maintained of the observations, medical or surgical interventions, and treatment outcomes. This record will include information that the patient provides concerning his or her symptoms, their medical history, the results of examinations, reports of any x-rays and labs, diagnoses, and treatment plans. Medical records and health information technician will organize and evaluate these records for completeness and accuracy. Coding is the process of translating this written or dictated medical record into a series of numeric or alphanumeric codes. Coders will regularly communicate with physicians and other healthcare professionals to clarify diagnoses or to obtain additional information. Coders will often use computer programs to tabulate and analyze data to improve patient care, better control cost, provide documentation for use in legal actions, or use in research studies. Technicians who specialize in coding are called medical coders or coding specialists. Medical coders assign a code to each diagnosis and procedure by using a classification system. Coders may use several reimbursement systems, such as those required for ambulatory settings, physicians' offices, or long-term care. Most coders will specialize in patients' medical information for insurance purposes. Physician-based coders will review charts, assign CPT, HCPCS, and ICD-10-CM codes for insurance billing. This is tied directly into physician reimbursements, and careful thought to assigning the correct codes is essential for physician livelihood. Technicians who specialize in coding for hospitals are called health information coders, medical record coders, coder abstractors, or coding specialists. These technicians will assign a code to each diagnosis and procedure, relying on their knowledge of the disease process. Coders then use classification systems to assign a patient to one of several hundred Medicare Severity Diagnosis Related Groups, or MSDRGs. The MSDRG will determine the amount for the hospital that will be reimbursed if the patient is covered by Medicare or other insurance programs that use the MSDRG system. Risk adjustment coding will focus on diagnosis coding using the ICD-10-CM code set. Risk adjustment diagnoses are pulled from claims data and medical record documentation within all settings. Risk adjustment coders can work for health plans, providers, or other healthcare entities. The coding profession is unique, and once it is mastered, continuing education must be ongoing. Code updates and policies are changed as often as quarterly. It remains important to stay abreast of these changes in order to ensure proper coding and payments. As technology advances, the role of a coder will continue to broaden and the job responsibilities will alter. For example, as EHRs were implemented, coders were required to become familiar with the EHR computer software, maintaining EHR security, and analyzing electronic data to improve healthcare information. Coders often took on a role on the EHR implementation team for a more successful outcome. As technology moves into artificial intelligence, the role of a coder will once again broaden and will require a coder to adapt to a new role of quality control or auditing. Coders may find themselves on a team to evaluate and implement that AI technology. Therefore, it is beneficial for coders to understand AI and how it is being used today. As a coder, it is important that you have a firm understanding of anatomy and medical terminology. Simple words such as if and or can completely change a code selection. Special attention to the many guidelines as well when learning the codes is necessary. When you visit a physician in the office, you typically get one bill from the physician, although you may get a second bill from another physician, such as a radiologist. When you visit the hospital, you typically get one bill from the hospital and then one from each of the physicians that are involved within the patient's care. Codes for physician services will report the work and overhead of the physician, regardless of where the work is performed. A physician can provide inpatient or outpatient services and can provide those services in a clinic, ambulatory surgical center, hospital, or other location. The physician services are reported using CPT, HIPAA, and ICD-10-CM. Physician services are typically billed on a CMS 1500 form. Codes for hospital services will report the technical component of services that are provided in the hospital facility or in a building that is owned by the hospital. These services are to cover the costs of the hospital itself and the overhead of the equipment, the technicians, nurses, and other supplies that are provided by the hospital. Hospital services are reported using ICD-10-CM and ICD-10-PCS, and they are grouped into payment classification systems such as MSDRGs and APCs. Hospitals will typically bill on your UB04 claim. As with most processes in the 21st century, technology can be used to increase efficiency and allow rapid access to vast amounts of information and data. The process of medical coding will be no exception. The skilled medical coder must be able to understand the basic functionality of medical coding software and its place within the real world of medical coding. There are a number of medical coding software tools that are available for use in the medical coding industry. Most medical coding software will allow you to search for a code, understand procedures in lay terms, check NCCI edits, and locate medical policies like the LCD policy that's listed above. A benefit of medical coding software is that it is constantly and consistently updated with the latest information, codes, and content. Some programs may offer add-on subscriptions such as CPT Assistant or the AHA Coding Clinic, and some examples of electronic coding tools available will include Codify by AAPC, TurboCoder, and Encoder Pro, to name just a few. Medical coding software may be used as a standalone tool, or it may be integrated into practice management, billing, and EHR systems. Physician services are provided by a variety of medical providers. Each provider has differing levels of education. Physicians will undergo 4 years of college, 4 years of medical school, plus 3 to 5 years of residency. Residency is training in a specialty of practice. A physician can continue to train in a subspecialty, and that is referred to as a fellowship. Physicians often have mid-level providers working in the same office. Mid-level providers can include physician's assistants or PAs and nurse practitioners or NPs. Mid-level providers are also known as physician extenders because they extend the work of that physician. Physician's assistants are licensed to practice medicine with physician supervision, and a physician assistant's program can take approximately 26 and a half months to complete. Nurse practitioners will have a master's degree within nursing. Mid-level providers are often reimbursed at a lower rate than your physicians. Although the scope of practice will vary by state, mid-level providers will require oversight by a physician. Each state will have regulations on the scope of practice that can be performed by each level of your providers. Although some patients may pay in full for their own medical expenses, most patients will have some type of insurance coverage. As a coder, it is important to understand that individual payers may specify coding requirements. Insurance carriers are broken down into two groups, private and governmental. Private insurance carriers can also be referred to as commercial carriers, and they may also provide governmental plans, such as a Medicare Advantage plan, in addition to those private plans. Commercial carriers can offer both group and individual plans. Group plans are often offered through your employers. Individual plans are going to be purchased directly from the insurance carrier. And some examples of commercial carriers can include Blue Cross Blue Shield, Aetna, Cigna, and United Healthcare. Government insurers can include Medicare, Medicaid, and TRICARE. Medicare is administered by the Centers for Medicare and Medicaid Services, also known as CMS, and Medicaid is a combination of federal and state resources. TRICARE is going to be for armed forces personnel and their families. Medicare is broken into several parts. Part A covers inpatient hospital care, as well as care provided in skilled nursing facilities, hospice care, and home health care. Part B will cover medically necessary physician services, outpatient care, and other medical services that are not provided by Part A. Part A is also called Medicare Advantage. This coverage is maintained by private insurers, and it may include a combination of Part A, Part B, and sometimes Part D services. And then your Part D service is a prescription drug coverage program, and those are available to Medicare beneficiaries. Coders working in physicians' offices will mainly work with Part B Medicare or Part C Medicare Advantage. Documentation is the recording of pertinent facts and observations about an individual's health history, including past and present illnesses, tests, treatments, and outcomes. The medical record chronology will document patient care to assist in a continuity of care between providers, facilitate claim review and payment, and then it can also serve as a legal document. It is imperative that all services provided to a patient be supported and documented within the medical record. A coder is required to read and understand the documentation within a medical record in order to code accurately the services that are rendered. Different types of services are documented in the medical record, such as your evaluation and management services, operative reports, and x-rays. Evaluation and management services are often provided in a standard format, such as SOAP. Not all E&M documentation will be documented in a clear SOAP format. However, each chart should always contain the components of the visit. So your subjective is going to be your information that's in the patient's statement about their health, including any symptoms. So the patient comes in for her annual diabetic foot check. The objective is going to be where the provider assesses and documents the patient's illnesses using any observation, palpitation, auscultation, and percussion. So here on exam, she has elongated, thickened toenails 1 through 5 bilaterally, which are mycotic in appearance. Finding is consistent with fungal toenails. They discussed any diabetic foot care, and she has intact sensation, no ulceration is seen, and all pulses are present. The assessment is the evaluation and conclusion made by the provider. So here we have fungal toenails, diabetes mellitus, and then toenails causing pain. And then your plan will be the course of action. So they trimmed the toenails manually with a grinder, and they will follow up in 10 to 12 weeks. Operative reports are used to document the detail of a procedure that is performed on a patient. Most of your operative notes will have a header and then a body within the report. The header might include the date and time of the procedure, the names of the surgeon, co-surgeon, or assistant surgeon, the type of anesthesia, and then the anesthesia provider's name, any pre-op and post-op diagnoses, any procedures performed, and then your complications. The body of the report might include the indication for the surgery, the details of the procedure or procedures, and then your findings. Typically, about 20% of an operative report will contain words that are less important to a coder. A coder will be tasked with breaking down the information and applying that correct code. As you read through the note, you will want to highlight any terms that are unfamiliar to you, and this will remind you to research the terms so that you have a better understanding of the procedure that is performed. In this example, it is helpful to understand the terms intra-articular and saucerized, and then the abbreviations ACL and SMC, and then the location of an anterior horn and posterior horn of the meniscus. When you're coding for diagnoses, you want to choose the correct ICD-10-CM code based on the most accurate information that is provided within the record. If both a preoperative and postoperative diagnosis are present, you want to code the postoperative diagnosis. You also want to make sure to review the body of the report in order to ensure that there are not any further defined or additional diagnoses that should be reported. If a pathology report is available, you want to review that and use those findings to report your diagnosis. When you are coding the procedures, you first want to start with the procedures that are listed within the heading. Make sure to read the entire note and the description of the procedure to make sure that the procedure listed in the heading is accurate. It is possible to find procedures that are documented within the body that are not listed within the procedure. This will ensure that you are capturing all of the procedures that are performed by the provider, and it will ensure that the provider is being reimbursed appropriately. When reading the operative report, you want to look for words that will help choose the correct procedure codes. Some of the keywords to look for are location or anatomic structures, surgical approach, procedure methods and types, size and number, and then any surgical instruments that are used to perform the procedure. Be sure to read through the entire operative report. There will be information in the body of the report that is not found within the header. You want to pay special attention to any documentation that a procedure is abandoned, it is complicated, extensive, or that extra time was involved. This documentation may indicate that a modifier is necessary. As we all know, just because there is a fee for a code, that doesn't mean that the provider will automatically be reimbursed. In order for a carrier to reimburse for a service, they have to believe that it is medically necessary. According to CMS, the definition of medical necessity is services or supplies that are appropriate and needed for the diagnosis or treatment of a medical condition. They are provided for a diagnosis, direct care, and treatment of that medical condition. They meet the standards of good medical practice within the local area, and they are not mainly for the convenience of you or your doctor. There are regulations that govern medical necessity that are found in the Social Security Act. CMS develops policies that are based on items or services that are covered by that act. CMS is not allowed to cover any items or services unless it has been put through legal requirements. The statutory and policy framework in which national coverage determinations are made may be found in Title 18 of the Social Security Act, and then in Medicare regulations and rulings. National coverage determinations, or NCDs, will describe whether specific medical items, services, treatments, procedures, or technologies can be made for Medicare. Medicare Administrative Contractors, or MACs, are responsible for interpreting national policies into regional policies. Those are called Local Coverage Determinations, or LCDs. LCDs only have jurisdiction within their regional area. MACs may also define what codes are needed for coverage in related billing articles and coding articles. Here we have an LCD for routine foot care from Novitas, and that is going to be a specific CMS contractor. This snapshot will show the contractor name and numbers, and then what type of MAC contractor they are. Just as a note, LCDs can be found online at www.cms.gov. Providers should use an ABN when a Medicare beneficiary requests or agrees to receive a procedure or service that Medicare may not cover. The ABN is a standardized form that explains to the patient why Medicare may deny that particular service or that procedure. Additionally, an ABN protects the provider's financial interest by creating a paper trail that CMS requires prior to the provider being able to bill the patient for payment if Medicare does deny coverage for that stated procedure or service. Providers are responsible for obtaining an ABN prior to providing that service or item to a beneficiary. The forms must be filled out in its entirety, as well as the cost to the patient and the reason why Medicare may deny that service. Only the approved form CMS R 131 is valid, and the forms may not be altered in any way other than to put the practice information in the header area. As we discussed in the beginning, the healthcare industry is a heavy regulated industry. HIPAA is the Health Insurance Portability and Accountability Act of 1996. HIPAA is a 5-part act, but the part most concerning to the position of a medical coder is Title II, which is also known as the Administration Simplification. Administration simplification addresses national standards for electronic transactions and code sets. It establishes unique identifiers for providers, health plans, and employers to be used nationally, and it provides federal protections from the privacy of personal health information. HIPAA required the ASC X12 4010 standard for electronic transactions to be updated to 5010 as of January of 2012. This implementation was essential in moving forward with the transition of ICD-10 CM. The code sets that are mandated by HIPAA will include HCPCS, CPT, CDT, ICD-10 CM, and NDC. It is important to remember that although HIPAA mandates the use of the specified code sets, it does not mandate the use of its conventions or guidelines, with the exception of ICD-10 CM. The Health Information Technology for Economic and Clinical Health Act, also known as the HITECH Act, it was enacted as part of the American Recovery and Reinvestment Act of 2009, and it was signed into law on February 17, 2009, to promote the adoption and meaningful use of healthcare information technology. Subtitle D of the HITECH Act addresses the privacy and security concerns that are associated with the electronic transmission of health data, in part through several provisions that strengthen the civil and criminal enforcement of your HIPAA rules. HITECH has strengthened HIPAA rules and has established more responsibility for business associates that are complying with HIPAA. HITECH also allows patients to request an audit trail of your health information that is made through an electronic record. On the website for the Office of Civil Rights, or the OCR, you can find case examples of violations of the HIPAA Privacy Act. In this example from the website, it shows where a nurse practitioner accessed her ex-husband's medical records, and she was reported to the licensing authority. More examples of violations can be found on the OCR website. The OIG acknowledges that patient care is and should always be the first priority of a physician practice. However, a practice's focus on patient care can be enhanced by the adoption of a voluntary compliance program. A voluntary compliance program will provide physician practices with many benefits, including a faster and more accurate payment of claims, diminished chances of a payer audit, and sending a signal to employees that compliance is a priority. Although a compliance plan is currently voluntary, the Patient Protection and Affordable Healthcare Act of 2010 will require physicians to treat Medicare and Medicaid beneficiaries in order for them to establish a compliance plan. The effective date will be set by future legislation. MIPS is a combination of three former Quality Initiative programs: the Physician Quality Reporting System, or the PQRS, the Medicare Electronic Health Record Incentive Program, or Meaningful Use, and then your Value-Based Payment Modifier. Together with one new component, which provides a single quality reporting system with a single payment adjustment factor based on the individual or group performance in Medicare Part B. MIPS is a budget-neutral program, meaning that successful reporters will earn positive payment adjustments funded by unsuccessful reporters who receive negative payment adjustments. Clinicians that are eligible for the MIPS program are physicians, nurse practitioners, physician's assistants, clinical nurse specialists, a nurse anesthetist, clinical psychologists, physical therapists, occupational therapists, qualified speech language pathologists, qualified audiologists, and registered dietitians or nutritionists. MIPS performance is based on 4 categories: quality, promoting interoperability, improvement activities, and cost. Quality is used to assess the value of care to ensure patients get the right care at the right time. Promoting interoperability is used to ensure the secure exchange of health information and the use of certified electronic health record technology, or CEHRT, for the coordination of care. The 4 objective measures are e-prescribing, health information exchange, provider to patient exchange, and then the public health and clinical data exchange. The goal of the improvement activities performance category is to promote access, population management, care coordination, beneficiary engagement, patient safety and practice assessment, participation in an APM, health equity, emergency preparedness and response, and integrated behavioral and mental health. There are approximately 90 weighted measures within this quality measure set. And then lastly, the goal of the cost performance category is to create efficiencies in Medicare spending. Cost measures assess a patient's total cost of care during the year or during the hospital stay and during certain episodes of care. Advanced APMs will include bundled payments for Care Improvement Advanced, comprehensive end-stage renal disease care, and then comprehensive primary care plus, as well as others. MIPS eligible clinicians who are on the participation list of one or more advanced APMs during a determination period or snapshot period are not required to report MIPS data. They may also qualify for a 5% incentive if they do achieve threshold levels of payments or patients through an advanced APM or the all-payer and other payer option. Snapshot dates are March 31st, June 30th, and August 31st. In October of 2000, the OIG published the OIG Compliance Program for individual and small group physician practices as a guidance for physician practices to create their own compliance plan. There are 7 key actions to a successful compliance program. They include conducting internal monitoring and auditing, implementing compliance and practice standards, designating a compliance officer or contact, conducting appropriate training and education, responding appropriately to defected offenses and develop any corrective actions, developing open lines of communication with employees, and then enforcing disciplinary standards through well-publicized guidelines. Another report that is published by the OIG is the OIG Work Plan. The OIG Work Plan is updated monthly on the OIG website. It outlines the OIG's priorities for the fiscal year ahead. A medical coder should be aware of the OIG Work Plan to know where it is focusing and where it will be going in the next coming year. So now that we have reviewed the Intro to Coding and Business of Medicine, you should be familiar with coding as a profession and for both professional and hospital coders, the different payers, types of documentation, medical necessity, and ABNs, the different regulations within the healthcare industry, such as HIPAA, compliance plans, and the OIG Work Plan, MIPS, and APMs.